Okay. Thanks so much for the lovely introduction, Tamar. Can I just check that that's all looking okay your end? Excellent. Okay, great. Well, tēnā koutou katoa, ko George Parker toko ingoa. That's a big warm greeting to everyone who's joined us today. My name is George Parker. We were absolutely honoured to be invited to present to the Birthplace Lab seminar series on some of the research we're doing deep down here in the bottom of the South Pacific. So thank you so much to Birthplace Lab for having us with you. And just to give you a little sense of where we're going to head with the presentation, Fleur and I are going to divide up the presentation roughly in half. I'm going to take you through some background context and some of the journeys that have led us into the present project that we're going to be talking about. I'll then be handing over to Fleur, who will take you through what we're up to in the present project. We will just do a little bit of adjusting the laptop to make space for one of the other of us. If you have any problems with sound, please just comment in the chat box and we will adjust our position in relation to the mic. So yeah, thank you. We are going to be presenting this presentation titled Better Together, Embedding Trans Inclusion in Perinatal Healthcare Through Participatory Action Research. Just a little brief note about language. Language is never universal and varies according to context, location, and across our different communities. But to give you a sense of how we're going to be using language in this presentation, we will be using trans as an umbrella term in this presentation as a form of shorthand, I guess, to include all people whose gender is different from the gender that was presumed for them at birth. So that would include non-binary and gender non-conforming people, as well as binary trans people. We recognise that as an umbrella term, or that all language is problematic or short-sighted to some extent, and that as used as an umbrella term, trans will encompass a broad diversity of experiences. And the way that we use it may include people who they themselves may not identify with trans as a way to describe their gender. The acronym that we use down in this part of the world to encompass gender and sexuality diversity is LGBTQIA+. So again, we'll be using that as an umbrella term to refer to all people whose diverse genders, sexualities, or all people with diverse genders, sexualities, and sex characteristics. And we acknowledge the incredible range of culturally specific identities within that. So here in Aotearoa, the culturally specific term used by our Indigenous Māori people is the term takatapui. So that when we use that term, we're referring to people who are Māori and have diverse genders, sexualities, and sex characteristics. And we acknowledge that there are cultural frames within Indigenous Māori worldview, as well as other Indigenous cultures that are completely different to how we might understand gender, sexuality, and sex characteristic diversity in a Eurocentric frame. So that's a little bit of a guide to the language. If we've used language that you haven't caught or followed, or that varies to how you might use it in your own context, our apologies for that, and we're really happy to answer or clarify any language at the end of our presentation. Tamar's introduced you to our learning outcomes, so we'll move on into the presentation. So who are we? Well, Fleur and I have the honour of presenting this research today, but we are not lone actors. We are part of a really vibrant community of researchers, clinicians, educators, community activists, and most importantly, parents who are either themselves part of the LGBTQIA plus communities in Aotearoa, or who are deep allies to our communities, often through their own personal connections within their whānau or family and their communities. So we're two of many, and what connects us us all is a very deep passion for building the capability of all of our sexual, reproductive, and perinatal health services right across that continuum of care to provide safe, affirming, and inclusive environments and interactions so that all of our diverse families have a peaceful, supported, and positive journey through their family building stages. So we won't tell you about all of us. We do think we're quite a fun and colourful bunch, though, and you'll get that vibe. So, to understand what we're up to down here in Aotearoa and to understand how we do what we're doing down here, we need to give you a little bit of context of Aotearoa New Zealand. And we frame that context around something called Te Tiriti or Waitangi, or the Treaty of Waitangi. So Aotearoa New Zealand is a colonised country. And what makes Aotearoa quite unique as a colonised country is that through the process of colonisation, our British colonisers signed a foundational agreement with the Indigenous people of Aotearoa that established the principles for how British colonisers and Māori, Indigenous people, would interact with each other, and that uh, assured Indigenous people in Aotearoa that they would have something called tino rangatiratanga, which is sovereignty or absolute authority over lands, settlements, and taonga. Taonga meaning treasure, all that is and was valuable. So unlike many colonial contexts, we have this foundational agreement that has asserted and assured Māori the right to self-determine, and that really gives all people in Aotearoa, whether from British colonial descent or the Indigenous people of this country, or those who come from elsewhere, a set of guiding principles for how to interact with each other, and for us as health researchers to always do our health research and to ensure health service delivery that upholds the self-determination of our Indigenous people and that commits to actions and initiatives that uphold equity and self-determination. So that's our colonial context, and then we also have a context surrounding our perinatal services. So our perinatal services are publicly funded through our government, through our tax take. All birthing people in Aotearoa have a choice of who their lead provider will be. And for the vast majority of our birthing people in Aotearoa, that will be a midwife as their main provider who leads and coordinates their care. So we're looking at about 90% of all birthing people will have a midwife. That will not usually be the exclusive provider, but that midwife coordinates their care and facilitates the involvement of other providers such as obstetricians and hospital services. And all people in Aotearoa generally have a choice of where they give birth, ranging from home birth through to tertiary health centres, and choice being, of course, couched according to kind of individual circumstances and risk profiles, things like that. The focus of our presentation today is going to be on a component of this perinatal continuum of care, which is perinatal mental health services. So they form part of our continuum of perinatal care, and they sit at the interface between publicly funded perinatal services and publicly funded mental health services. So during the perinatal period, you will access perinatal health services, perinatal mental health services via referral from a midwife, a GP, or when you're an inpatient in any antenatal or postnatal wards. If you've got mild to moderate distress, you'll generally be supported in primary care or by private providers. However, moderate to severe distress that meets the criteria will be seen through specialist perinatal mental health services. And those services tend to be concentrated in our main centres. Those services provide multidisciplinary, community-based assessment and treatment, some respite or residential care beds, and very occasionally acute inpatient perinatal care beds. But that coverage of those is very patchy around the country. And it's probably always useful to say we're a relatively large country proportionate to our population. Our population for Aotearoa sits over just over 5 million, which I fully acknowledge is a probably average sized town in many parts of Canada. Kia ora. So, the precursor to the project that we want to talk to you about today was a project called the Trans Pregnancy Care Project. We ran that project from about 2021 through till about 2023. And there's certainly been a burgeoning amount of evidence internationally pointing to some challenges within perinatal care for trans people and their families. But prior to the Trans Pregnancy Care Project, we had absolutely no knowledge about how our trans families were experiencing perinatal care here in Aotearoa, New Zealand. We didn't even know like if they were in this, well, we knew they our families are always in the system, but we had no data collection that could even tell us who our trans families were, let alone how they were experiencing care. We got some Health Research Council of New Zealand funding, and we undertook the project. It was a two-phase project. The first phase set out to find our trans people and families going through their birthing journeys and to ask them about their experiences of care. Phase two then went out to our perinatal workforce through a survey-based approach to kind of say, what do you know about trans people coming through your care? What education support knowledge do you have to ensure that the care you provide trans families is of a sufficient quality? In phase one, this is just a quick snapshot. An 80-page report becomes a single sentence, which was that so we interviewed in depth 20 families that had either a gestational or non-gestational parent who was trans. For some of those families, both or multiple parents were trans. What we heard was that there were pockets of really amazing care, generally provided based on the shoulders of absolutely passionate providers who had developed their own self-knowledge, usually because they were part of our LGBTQIA plus communities themselves. But they were doing that in a system that routinely and systematically erased, excluded, and harmed trans people. So we had a systemic problem being propped up by passionate individuals. And I'll be super keen to hear about what your experience in Canada is of that. In phase two, and of course this was kind of consistent with phase one, perinatal providers told us that that for the most part, people wanted to get it right, but had lacked leadership, knowledge, resources, and opportunities to learn, and therefore struggled in a system that wasn't supporting them to provide trans inclusive care. And there were many, many, many powerful things that the trans people and their families told us, but Nick, who was non-binary, said, and this was Nick talking about actually at that time their fertility care, it feels like I don't ever get to be myself in the service or in that space. And it means like every time I go in, I have to tuck a part of myself away. And then I have to come home and unpackage that myself. Yeah, so I guess it's painful. It feels really disempowering. And that quote from Nick's going to give us some important steers when we talk more about our perinatal mental health services. So, at the conclusion of the Trans Pregnancy Care Project, and in support and guided by our takatapui, so our Māori gender and sexuality diverse team members, we were invited to develop a guideline and a set of recommendations for trans inclusive perinatal care based on a really beautiful framework called Te Whare Takatapui, which we're going to tell you what that means in a minute. And And this framework has six Indigenous values that says that if we embed those into perinatal services, we are creating conditions for safety, warmth, and care for all of our LGBTQIA plus people building their families. The guideline also kind of approached guidance to perinatal care providers, really emphasizing that individual provider change without whole of system change wasn't going to work. That actually so many of the challenges experienced by trans people in perinatal care operated at a systemic level. We're going to give you some examples of that later on, but just to give you a sense of the guideline. And so lots of the recommendations were about system level changes, and where we focused on individual provider change, it was very much focused not on learning all about who trans people are, but much more orientated to critical self-reflection on behalf of perinatal providers on where their norms, power and privilege stemmed from the worldview, the dominant worldviews they held about gender and sexuality. So we can't do justice to the Te Whare Tāpoi framework. If this presentation sparks interest, we'd really invite you to go and have a look at the guideline that does it much more justice. We have permission from Dr. Elizabeth Kirikiri, who's a Tāpoi scholar, to just introduce you to the framework, but the knowledges are hers and belong to Māori. But essentially, it provides conceptual and practical ways to improve LGBTQIA plus people's health and well-being, made up of these values. And when these values are accounted for, as I said, this whare or a meeting house, or as a metaphor for services, can shelter and nurture all people with diverse genders, sexualities, and sex characteristics. In the interest of time, I'm not going to take you any further into the values, but as I say, please, if you're interested in that framework and how Indigenous knowledge might be centred in guidance for perinatal care services, please do go have a look. I'm going to now pass over to Fleur.
Thank you. Kia ora. Ko Fleur Kelsey tōku ingoa. My name's Fleur Kelsey. Really pleased and excited to be doing this part of the presentation. So as George has taken you through kind of where this project came from, and once that project was finished, we kind of went, oh, there's more work to do. So putting together this project was part of progressing this work. So the project's called Warming the Whare because it's based on Te Whare Tāpoi, and it's about working with perinatal mental health services. And basically what it is it's a values-driven 3-year participatory action research project, and we utilise cooperative inquiry as our methodology. We're really focused on implementing and evaluating Te Whare Tāpoi framework and the Warming the Whare guideline into services, and it's a fully funded project. So one of the questions that's really useful is why perinatal mental health care? And what we saw through the Trans Pregnancy Care Project was that there was that real lack of system and workforce readiness, and that base assumption that all people that came through perinatal services were women and mothers, and that was the assumed service user. We know from other research that trans people are at higher risk of perinatal distress for a whole lot of the reasons that we know about what their health journeys have been like in general, and about the ways that they're treated in the system as they're building families. There was a really strong sense through the Trans Pregnancy Care Project that the services were perceived as unsafe, and that if the perinatal services were perceived as unsafe and people were traumatized through that journey, they were much less likely to then go into perinatal mental health care, even though they might have a really high need. So we saw that there was a real opportunity to build capability in both sectors, in the perinatal system in general, and also in the mental health sector. So that's kind of why perinatal mental health care. in talking about cooperative inquiry, just a bit useful to kind of sketch out what that looks like. It's a collaborative and participatory approach where people who are interested in working on the same things come together and we work as co-researchers and co-subjects. So it's not us researching people, it's us researching together and creating together. It's a really process-driven approach using cycles of action and reflection, and I'll talk about a little bit about what that looks like for this project later on. It's got a really explicit transformative intention. It's about changing things, and it's about changing things as we study them. So we don't do research and then decide what that research means. We research, change things, keep making meaning as we're traveling along in the project. And that's been one of the greatest gifts of this project is the ability to do that with such an amazing team. So we have a couple of pillars that are really important to us in this project and that form the basis of how and why we do things. One of those is intersectionality. We really acknowledge and work with that idea that people have power and privilege or disadvantage in many different ways, depending on who they are, and that needs to be accounted for in these projects. We are really centered on epistemic justice in that we want to center the voices of people who haven't had their voices heard. And the trans experience has been really absent from perinatal mental health care. And so for us, this is about bringing it really clearly to the table in all the interactions we do. And we do that in a number of ways, from having trans people on our research team, as well as an advisory group, which I'll talk about too. We're really focused on the idea of cultural safety versus cultural competency. So as George said, rather than that idea that you can learn all the words and all the things about trans people and then provide good care, we want people to reflect on their own culture, their own relationship to gender, and think about how that might impact on the care that they provide. And a whole lot of the work in this project is about relationships. We've been really lucky that it's a 3-year project because it enables us to really get to know our services, get to make strong connections between ourselves as researchers, and to build trust. And for us, trust has been a huge component of this project. And we like to say that our research goes at the speed of trust, because if we don't have trust, we can't move anything forward. We can't get people to participate. But when we can create trust, we can get some really amazing things happening. This is just some pictures of our services. So we have 2 specialist mental health services. The one on the left is based in Tamaki Makaurau in Auckland, and that's probably the biggest centre in the country. And they have quite a large team, and they provide community-based services from their site. They do have some inpatient beds, and they do have some community beds as well. And the teams comprise of things like psychiatrists, psychologists, social workers, occupational therapists, nurses, group therapists, and they do a huge range of therapeutic interventions depending on what suits each family. The one on the right is Wellington Specialist Maternal Mental Health Service, so one of our other larger regions, but they're a much smaller team and they're actually located where we're located as researchers. So I'll talk a little bit later about the difference between working with a team that's right in our area versus a team that's a bit more remote. One of the big components of our project, so we've got our research team, we've got our services, and we've got what we call the Trans Whānau Advisory Rōpū. So that is basically a trans family advisory group, and what they help us do is centre lived experience in the project. And we've used an advisory group as an alternative to engaging with past or current service users for a couple of reasons. We felt that it was probably unsafe to be asking current perinatal mental health service users who were trans to talk to us about their experience in a way that wasn't harmful for them. And because of the way that the services were operating, they weren't really able to identify past users for us to work with. So, what we did was we engaged three people to be on the Trans Advisory Ropu, and they've all got personal experience of pregnancy and parenting as trans, non-binary, and Takatapui people. So they're amazing, and we meet with them regularly and ask them for specific feedback on things um, and really work really hard to honour the experience and perspective that they give us. Um, and as the project's developed, how we work with them has developed too. And they've been really instrumental in giving us advice about some of the implementation activities of the project. So I want to kind of set the scene for what our project looks like and how that works in that cooperative inquiry process. So phase one of our project was the induction process, which is the first reflection phase in cooperative inquiry. And it's where we established our approach and created connection with the services. So it involved a half a day long meeting in each service where we started getting to know each other, and that's called whakawhanangatanga in Te Reo Māori, and that's a process that we do where we just start making connections, start finding commonalities, and start building that sense of trust. We did quite a lot of work around developing relationship protocols. How are we going to work together? What things are important to us? So that was things like for us as a research team, it was really important to care for the services. We recognised that health services in Aotearoa are really stretched and stressed at the moment. So we wanted to be like a warm embrace around them. So that was part of our relationship protocols. And we also introduced the services to Te Whare Takatapui and took them through the values and talked about why these things were important and how we could connect them to them. Phase two was the prioritisation framework development, which was the first action phase. So what we did was we did some data collection. So we did lots of individual interviews, some focus groups. We did a documentation review where each service provided us with all their documents and we had a look through them, and we did service walkthroughs in each service to have a look at the physical space, have a look at the journey of trans whānau through the service from referral to discharge, to kind of capture the places where care happened and to start getting some ideas about where we might be able to implement changes. We then brought this back to the services and workshopped those insights and said, this is what you told us. Does this resonate with you? And then we actually workshopped with them what next? Where do you see the implementation priorities to increase capability? So they provided us with a whole lot of information and we agreed on the things that we would do with them. Phase three is the implementation and evaluation, which is the second action phase. This is where we're getting on and doing these implementation activities. It's a really reflective and reflexive process and lots of problem solving and refining. And as part of that is a process and outcome evaluation as well. So we're in that phase now. We're a little over halfway through that phase, aren't we? So we're just starting to do some process evaluation formally and obviously keeping on refining how the implementation of things are going. Phase four is when we have a really deep reflection on the knowledge that we've gained and we think about how we can communicate that to other people. So other mental health services and other perinatal services. And the idea is that our services become kind of peer support champions of this work and can really talk to other services about how they might go on this journey too. So it's quite big. Some of our findings were that there was a really strong commitment to doing this work and a great awareness that the current practices excluding and harming trans clients through embedded norms, and not reflecting diversity, but that people had really limited experience providing care to trans people, and that they had a huge fear of getting it wrong.
Mm.
So fear was something we've really had to work with in this project. Um, there were some priorities for implementation that were really similar over both services. So they were interested in making sure that their name was affirming for trans people and didn't put people off. One service was named Aotearoa, formerly Maternal Mental Health.
I've made it halfway.
Halfway made a change to a more inclusive name. And the other service is called Specialist Maternal Mental Health. So there's definitely some issues from the very start there. They were interested in making sure their documentation supports visibility for trans people and assists in care. There was some work on physical spaces, work on inclusive language, but a big desire of the services was an education package that actually supported ongoing reflective practice around capability as well as building some of their knowledge. There's a couple of challenges for a cooperative inquiry project. Challenges for us was these two services and two sites to work in, and two services that were actually at slightly different points in their journey, and how we worked for that. And so it's been a lot of flying to one of the services, whereas the other service we can pop in.
Hmm.
And so the difference between popping in once a week or once every 2 weeks and actually being on site in the other service once every 2 or 3 months has been huge for how that trust has worked and how building the relationship has worked. So it's been quite tricky. There's slightly different service provision capabilities with each service as well, and slightly different models of care. So one of the services was actually already seeing non-gestational parents as someone to provide care to, whereas the other service is very much that only the gestational parent is able to have care provided. So they were already thinking about families and family structure in a different way. There's challenges on projects with resourcing always. How do we effectively use the money that we've got on this project to do the work that we need to do? And for all of us, there's always that impact of increasing anti-LGBTQIA plus right-wing rhetoric, which is happening here in Aotearoa and obviously all around the world as well. And it impacts on those of us that are trans in a way that makes doing this work difficult sometimes, but also provides us with hope, because actually doing this work is also really uplifting. So challenges and supports, I guess. A whole big part of cooperative inquiry is confusion, uncertainty, and ambiguity. You don't really know what's going to happen when you sit in a room with people and make plans. And so sometimes we feel nervous that it's not going well, or that people aren't on board. And basically, you have to sit there and keep doing it. So it's that one step forward, one step back, and thinking that you've communicated what it is that you want effectively, but it's been missed sometimes. So the time is a challenge as well. The time is also an opportunity, though. And there's some other really strong opportunities that come from doing cooperative inquiry, which is we get to value diverse worldviews and ways of knowing. And we have that really strongly in our project. And that looks like centering Māori Indigenous knowledge in a way that's intentionally decolonising. We get to draw on lived experience and really uplift those voices that haven't been heard before in these settings. And we get to have this really amazing conversation about the trans experience in conversation with health professionals' own experience of care provision. And we get to figure it out together. Being a 3-year project, the time to form effective relationships that allow for deep reflection has been an absolute gift. And it's meant that we can meet people exactly where they are, and work from there. And it's also given us the opportunity to have that space to do sustained challenging of cis heteronormativity in systems and practices, which is really at the heart of this work.
And if you're a gardener, it's like weeds. You pull it out, it springs back up again.
Yeah.
Constantly weeding.
Yeah. Yeah. And final thought slide. So we believe that cooperative inquiry is ideally suited to health research focused on building capability for inclusion. It democratizes knowledge production. It enables the naming, interrogation, and addressing of exclusion, which is necessary prior to any inclusion initiatives. The cycles of action and reflection promote individual and collective insights and perspectives, which can lead to changing worldviews and practices. So it's getting people's heart as well as their minds, and doing that in a way that really resonates with them because they've been involved in the process. And it means that the services own the solutions, and hopefully change persists beyond the lifespan of the project, which is what we're really all about, because we're really aware that we will be finishing with them in a year and a bit, and we want this work to continue without us, because they have done the work to be able to change what they're doing.
Okay,
Kia ora.
that's us, Tamar.
That's us. And just some of our contact details. We have an Instagram for Warming the Whare Project, and you can email George as the lead investigator or our research fellow. And I've just put up this article here, which, especially if you're interested in Te Whare Takatapui, will give you just a bit more of a, well, we hardly gave an explanation, so
Yeah.
a much more kind of robust explanation for an international audience.
Of our guideline.
Yeah, of the guideline.
Great. Thank you so much for an amazing presentation. At this point, I am going to stop the recording and open up the floor to questions.